All right, we're going to get started because I have to read the disclaimer you've all heard now, but humor me. Good morning and welcome to the Home Health Quality. The Goal is Staying Home, presented jointly by the Alliance for Home Health Quality and Innovation and the Visiting Nurse Associations of America. This session is being recorded. This continuing nursing education activity has been approved for one contact hour by the Maryland Nurses Association, an accredited approver by the American Nurses Credentialing Center's Commission on Accreditation. In order to receive your certificate of completion, you will need to attend this program in its entirety and complete the evaluation, available in the conference app. Certificates of completion are available at the registration desk. Our faculty has disclosed no financial conflict of interest. A copy of the full disclosure sheet is available on the table outside the room. I'd now like to introduce today's presenters. Christine Lang is Senior Director for Product Management at Ability Network, leading the company's home health and hospice clinical analytics work. She has been engaged in clinical, operational, and financial analysis in the post-acute market for almost 20 years. Christy works with a number of industry stakeholders, including agencies, association, and advocacy groups, on ways to use data for improving patient outcomes and organizational performance. Danielle Pierotti is Vice President for Quality and Performance Improvement with Visiting Nurse Associations of America. In partnership with member home health and hospice organizations across the country, she brings innovation to care practices, seeking to continuously improve practice and meet evolving patient needs. With that, I will turn it over to Danielle and Christy.
Okay, so how many of you have actually memorized the disclaimer by now? This is on. Okay, good, because we're recording. That's the only reason I get to do the Donahue thing. Got to hold it up here. Oh, God. Now it's more work. It's got to be up here. So first of all, thank you all for being here and coming to San Diego, and a big thank you for staying all the way to the end. It is always a little bit of a challenge to have the last breakout session of a conference, and we really appreciate the folks who stay all the way through. So thank you very much for that. Christy and I have worked together very, very closely, and we really want to talk to you today about home health quality and this goal that we are hoping you all will start to adopt some different language after this hour is over around the idea of staying home. So we have no disclosures. For CEU reasons, we plan to achieve these three objectives. So let's actually talk about what we want to talk about. Readmissions is the biggest word out there for everybody right now, right? We talk about readmissions in hospitals, we talk about readmissions in home care, we talk about readmissions ad nauseum. And my pitch to you today is, can we please stop talking about readmissions? So why are we all talking about readmissions? Well, we're talking about readmissions because they really are at the core of the triple aim, right? So a few years back, some incredibly smart people started to talk about what does healthcare in the United States really need to do to move forward and make positive change. And what came out of that was this very simple concept of the triple aim, which is now actually the quadruple aim, but we're going to focus on the traditional three parts of the triple aim: population, health, patient-centeredness, and lower cost, right? So the idea of repeated admissions to the hospital is a failure to all of those. When you are constantly going back in the hospital, it is very costly. It is not patient-centered because, let's face it, no one wants to be there. And it is not about the population. It's one patient at a time. And what I would really like to pose to you is that as we try and move the needle, move the conversation across the country into the triple aim, we as industry leaders in home-based care need to stop talking about readmissions, because readmissions is about the hospital. Whenever we talk about the readmission, we are putting the hospital at the center of the conversation and making them the most important people in the room. And it's not about them. It's about the patients. And when we avoid readmissions, what are we actually doing on the positive side? We're staying home, right? So if we can stop talking about the failure mode as being the readmission and start to talk about the goal, which is staying home, it's a really short trip to seeing why home-based care is the center of care. So it is also really, really completely supported and totally reasonable when you start to say days at home. How does that connect back to the triple aim? How do we help people see that we need to change this language so that we can change the focus and really put it on the patient? Well, we can anchor right in the triple aim. The first aim is population health. populations of people. That's about the community. It is about how each of us are part of that group. And when we are staying in our homes, we are in our communities. When we are in our communities, we are with our families. We can work with family units in homes. We work with communities in homes, because when we're doing it to the best of our ability, we're connecting with all of our neighboring resources. That is about building the population towards its greatest sense of health and not focusing so much on one individual at a time who's being readmitted as a failure of the system. Patient experience, I don't think any of you are going to be surprised by this. So we now all have, hospice is now on board with the Consumer Assessment of Systems Health of Patient Experience Surveys, the CAHPS, right? The CAHPS vary from setting to setting in terms of what the specific questions are. However, they all have universal questions, the global questions. Every single CAHPS setting survey includes the same global questions of overall rating and would you recommend this? When we look at hospitals who have been doing the CAHPS survey longer than any of us, who have had years of experience at a national level of trying to improve patient experience. There are huge industries that talk about patient experience in the hospital. They still can't get up above 72% on either of their global measures. They've been doing this for a really long time. One of the reasons for that is because nobody wants to be in a hospital. Home health, 84% for overall rating at a national standard and 78% for would recommend. We're already out of the gate with only a fraction of the effort and time and investment in improving patient experience, making people happier than hospitals are. And hospice, this is draft data only, but it's the first we've seen coming out of CMS on the hospice data. Right off the bat, 80 and 85%. People are much happier in their homes. If we want to talk about achieving the second part of the triple aim, patient-centeredness, already we need to be in the home. And cost of care. This is a no-brainer, but I just like these numbers because they really put it out there. I shared these with some hospital leaders recently, and they all did this. Oh. So we have two studies. We have an inpatient study from 2012, so that data is probably from 2009 because it takes a couple years from the time you get the data to when you can publish. But average cost of an inpatient night across this country was from $1,600 to $2,000 a night. A night. Home health care, $2,400 for 60 days of care. A night versus 60 days. I think the cost is pretty obvious. So when we start to talk about why home has to be the center of care as we move forward, it is because it fits the triple aim completely. And when we start to acknowledge that and own that, then we can start to change this language, because it's not about avoiding readmissions. That is a failure. When the patient gets readmitted, it is a failure. What we want to do is keep them at home. That's the success story. So we talk about days at home, and we start to help people see the world through a different lens by changing those words. I also want to point out something about readmissions. Readmissions has been on the profile and in the viewpoint of hospital leadership for years. Years and years and years. We start off in 2007 with a 19% national average all-cause 30-day readmission. Didn't really move. This is one of those things CMS was collecting and talking about for years. Then we get to 2012, it's 18.4%. Not much change in 5 years. So guess what CMS did then? They put money to it. That is the point where they announced that we were going to now start having fiscal penalties to hospitals whose readmission rates are too high. So they're penalizing that negative outcome of people coming back into the hospital. And in that 3-year, readmissions have been reduced by 2.8% nationally. There's money in it, right? So now we're all in it too, and we have a certain component that needs to go into this. What Christy's going to start to talk about now is what we know based on the available information for home health quality. Because Like I said, it's our position that the issue is not readmissions, the issue is staying home. So what we want to do is start to understand what can we all do better, what reduces the likelihood of people needing that failure mode, where do we put our emphasis as caregivers to say these are the things that increase the likelihood of keeping people at home. So I'm going to turn it over to Christy, who's going to start walking us through what we know about that at this point.
Thank you. So Danielle gave us a lot of great aspiration about how we should be focusing on days at home versus readmissions or hospitalizations. Unfortunately, the data that we have is on hospitalizations and readmissions. But I suppose if you're thinking about that being what you're avoiding, that's a great place to start the study and the analysis. Before I start talking about the numbers that we have on hospitalizations and what it tells us about our patient community, I want to introduce you to a young man named Pete Kosternick. Anybody know Pete's story? No familiarity? Well, last fall, Pete broke the world record for running from one side of this country to the other side of this country. He ran from San Francisco to New York City over 42 days, averaging somewhere in the neighborhood of 70 miles per day. Quite the feat, right? And we use the phrase, it's not a sprint, it's a marathon. Well, when we think about continuing to improve the delivery of care in the United States, it's not just a marathon, it is running across the entire country, maybe even further, right? And one of the things about Pete's story that I think about, I actually followed it on Facebook. He and I used to work at the same company, so I knew that he was going on this journey, and I followed his updates on Facebook across the country. He had done incredible amounts of preparation, research about weather conditions, topography, you name it. And yet, as he progressed, he had to make adjustments on a daily basis. The weather wasn't as planned, he got sick, roads were closed for construction. There were all kinds of things that got in the way of him achieving his clear ultimate goal, or things that he had to adjust to. And I think of that in terms both of what CMS is doing in terms of putting out new incentives. They know that we want to reduce hospitalizations, we want to move towards the goals of the triple aim, and they keep trying different incentive programs, different payment models, different ways of approaching measurement, trying to tweak to ultimately get us to that end goal. And as providers, we need to do the same thing. We need to constantly be taking in information and adapting to either what CMS puts in our way or what other new information we learn about our own operations or our patients and the way that we move towards our end goal. So we're going to tell you some of the data that helps inform that journey. First of all, I want to let you know where the data is coming from. There are two main sources of information on the upcoming slides, and each slide has been noted with the data source. So if you're curious about where that's coming from, it's the Home Health Compare database, which represents all agencies in the United States. It's labeled by the date of publication. And because we're talking about hospitalization measures, those measures are actually 9 months behind. So if you see a date label of January 17, that's when it was published, and it represents second quarter of 2015 through first quarter of 2016. We also have data from the Ability database, so that's going to represent about 1,000 agencies, and in this analysis, we're pulling in data from fourth quarter of 15 through third quarter of 16. It's a little bit more recent, but the more important thing is we can dive into it in greater detail and look at some of the variability based on different patient subsets. The other important thing to note about the timing is that hospitalization measures are unique. When we talk about a hospitalization measure from first quarter, it's based on the patients who are actually admitted to home health during that first quarter rather than the patients who are discharged. So just so you have some familiarity with that. One of what I see as a challenge in really coming together as a healthcare community around the issue of hospitalizations is the various ways that we measure it. Each measure has a specific purpose. It serves a goal to understand a specific component of healthcare, but it's really challenging to understand that there are multiple ways of measuring basically the same concept. And then when you have different measures and you don't know which one is which and how they align, it can really add a lot of complexity to the conversation. So there are three main measures that we talk about in home health, and I want to spend just a couple minutes talking about the difference between each of them because they are kind of apples, oranges, and bananas. The two 30-day readmission rates. We talk about a hospital 30-day readmission rate and a home health 30-day readmission rate, which you would think they'd be pretty darn close to each other, but they have some key differences. First of all, when you talk about a hospital 30-day readmission rate, especially in the context of the payment penalty program, you're talking about all patients who are discharged from that hospital. When you're talking about home health, it's of course patients who are discharged from a hospital and admitted to home health within 5 days of that hospital discharge. So when we're measuring hospital readmission rates, people don't care about where the patient was post-discharge or how quickly they got to that next destination. For home health agencies, we're looking specifically at those patients who are discharged within the 5 days prior to admission. The window of that 30 days starts from the day of the hospital discharge for the hospital readmission rate, and not too surprisingly, starts from the home health admission date for our home health version. Both are going to be based on Medicare claims, but I wanted to mention that when I use ability data in this conversation, we're actually basing it on the OASIS. How closely those two map is a little bit difficult to evaluate because of the way that CMS publishes 30-day readmission data for home health agencies, and we'll talk about that in a minute. One other thing to note, for home health, LUPAs are actually excluded. So anytime a patient hasn't yet received at least 5 visits, that patient case is thrown out of the calculation. For the 60-day hospitalization rate, it's a little bit of a different mindset, and this is why it's bananas. We're talking about all patients who are admitted to home health, regardless of where they were prior to that home health admission. So that's why we use readmission and hospitalization, and why sometimes somebody will say readmission rates. I'm like, wait, are you talking about readmissions or hospitalizations? Because, of course, about 40% of home health patients weren't in a hospital prior to home health. So that kind of expands the population that we're talking about. This, of course, is 60 days from the home health admission date, also based on claims when Home Health Compare looks at it. When we look at it, we're basing it on OASIS, and we can evaluate how closely those two measures align in this data set, and they're pretty close. For almost all agencies, they're plus or minus 2%, those two rates together. So it's not ideal to be looking at different data sets, but the flexibility and the timeliness that it gives us makes it worth it. And then again, LUPAs are excluded. So when we look at these 3 rates side by side, we've got the hospital 30-day readmission rate coming from Medicare of 15.6%, our home health 30-day readmission rate coming from our database of 13.2%, and our 60-day hospitalization rate coming from Home Health Compare at 16.3%. Not a huge difference. Well, first of all, a nice drop between the hospital, all patient, and those patients who are in the home health. So home health appears, based on this analysis, to be helping to reduce that readmission rate. See, I have to catch myself using the right terms. That 30-day readmission rate. But not a huge difference between the 30-day readmission rate and the 60-day ACH rate, even though we're adding a full 30 days to the calculation. That's because of 2 things. 1, we see more hospitalizations early on in care. 2, patients who were in a hospital prior to home health have higher hospitalization rates than patients who weren't in a hospital prior to home health. So we see a little bit of a bump up when we add that second month on, but not a dramatic increase. So this is one thing that always perplexed me about the way that CMS was calculating these, the fact that they remove LUPAs. It makes sense to remove a LUPA maybe if the hospitalization happened after that LUPA. If the patient only needed 4 visits and then 2 weeks later they were readmitted, that doesn't seem like it should count against a home health agency. But we know that there are a number of LUPAs that end in a hospitalization in that first or second week of care. So there's a little bit of a tug of war going on there. So what we have here is just kind of looking at if we include all cases versus excluding the LUPAs, what does that do to the rate? And you can see for both that 30-day readmission rate and the 60-day hospitalization rate that when we include LUPAs, we do see a higher rate than when we take them out. So 30-day readmission reporting from Home Health Compare. Hopefully everybody's familiar, has maybe taken a look at your own Home Health Compare publications recently. So they give us nice numbers for most of these measures. For the 30-day readmission rates, they actually just tell us if you're same as expected or if you're worse or better than expected. And they talked about the importance of this, especially for this particular measure, because of the large variability in readmission rates, publication to publication for smaller agencies. And CMS felt like it could be misleading to publish numbers that are having a lot of variability. They have not specifically, that I've seen, talked about why that doesn't also apply to the 60-day rate, except for the fact that we do have more patients included in that 60-day rate, so you have less likelihood of impacting that number. So this is looking at what we know from the CMS data around 30-day readmissions. I've got 2 points of reference here. January's publication of Home Health Compare last year, January's publication of Home Health Compare this year. In both instances, most agencies, 73% last year, 76% this year, were marked same as expected for 30-day readmission rate. Kind of begs the question for me, I'm not sure what the value is if so many agencies are same as expected, but CMS hasn't asked my opinion on that. What I do think is interesting is look at the difference between the percent of agencies who were marked worse versus better last year and were marked worse versus better this year. And also look at the count of agencies that were included. CMS has changed some of their parameters to include fewer agencies by requiring a higher minimum number of cases to be included this year than they did last year. And they've had a couple of other tweaks to which cases are included. So therefore, we've dropped about half of the agencies that are represented by this particular measure. Lots of agencies have not enough data to be reported. And yet at the same time, we now have almost a quarter of all agencies that are marked as worse than expected, and only a tiny sliver that are better than expected. What's that? That's a good question. So the comment was they make the numbers come out the way they want. I think that's probably true in some instances. You know, they're statistics and damn statistics. You could make them say whatever you want them to say. But yeah, in this instance, I don't know what the motivation would be to show more agencies as worse than expected. Yes, ma'am. What is the threshold? It's a minimum of 20 cases. A year. 20 denominator, so 20 eligible patients. So there are also some criteria related to which are considered eligible cases.
So only 4,800 agencies had 20 or more eligible cases?
Yep, exactly. That is a good question. And I think they changed. There are a lot of very small agencies out there. I think the median reimbursement, Medicare reimbursement for an agency is like $1 million, something like that. So there are a lot of very small agencies out there. They want this to back up their MedPAC claims. Well, and so the comment was they could back up the claim that there's high profit margins and not great outcomes. There's some interest, so I'm going to get to some data that kind of points in that direction to a certain degree, although it doesn't have the same kind of variability in the way that the numbers have been calculated. But an interesting discussion I had just yesterday on that data point in just a moment. Yes?
So I wonder if there's any data on SNPs that correlates with this, because I wonder if this is sort of...
Do you want to take a note on that? That is a good question, if there are numbers for SNFs and how they match up. So that could be something that we could look into for next time.
I think that this is a fascinating point of conversation. I think it's a fascinating point of conversation. And the other thing I would point out is that what this really illuminates is how carefully you have to pay attention to the small print in any statistics, right? Because if Christy had not included the 10,000 versus the 4,000, we would all be having a very different reaction here. So that's one of the points, I think, of Christy's whole presentation is how carefully we have to pay attention to the labels and have a real engagement with which data are we showing to whom and when and how. The point about MedPAC, to me, that's a chicken and the egg question. I don't know which came first. But if I saw this, I might be more inclined to agree with some of those statements. So I don't know, but thank you for those insights, and we can start to look for some of those other points to understand this better. But Christy's got a ton of good stuff.
Yes. All right, so from here on out, we're actually going to set the 30-day readmission number aside, and only because there's not only, for a couple different reasons. One, because there's a lot more data on the 60-day hospitalization rate. We get deeper CMS data, and we have more cases, so we can kind of dig into it and look at subsets with more confidence. Also because right now in home health, it's one of the biggest measures. It's included in star ratings, it's included in value-based purchasing, and 30 days moving in that direction, but it's not there yet. We also know that agencies with higher or lower 60-day hospitalization rates also have higher or lower 30-day readmission rates, so there's a lot of similarity in what agencies are doing well or struggling within those instances, using those two different measures. So what we've got here, and this gets to the point that I was just referencing a moment ago. This is our trend of 60-day hospitalization rates from the publication in January 2015 all the way up through the publication of January 2017. And I could tell you in the April publication, it bumped up another notch. It's now 16.5% nationally. So this is an interesting dynamic that for all the effort and attention that we're putting on this particular issue, we are not seeing an improvement. If anything, we're seeing the direction go the wrong way, right? The trend going the wrong direction. The interesting conversation that was had on this yesterday when I showed this same slide was the room, and this was in Arizona, so these were Arizona providers. It may be part of what's going on in their state, but almost everybody almost simultaneously said they're discharging them sooner. They're discharging them sicker. Hospitals are getting rid of patients quicker. And we had a conversation about this being a trend that we've seen over time, but recently having another bump in that trend. So it creates this challenge where we have reimbursement coming down, we have sicker patients with higher acuity needs coming in. We're being measured against this particular measure that doesn't, the three aren't in alignment, right? We can't be good at all three simultaneously.
To back that up, just compared to the case mix index and why we faced rebasing according to CMS, because we were gaming the system.
Talking about rebasing case mix and the fact that case mix has come up and CMS says there is not a demonstrable change in the patient population that matches this change in case weight, so they're bumping the case weight down. And that analysis has always been a couple years old, so I wonder if we evaluate that for the 2016, 2017 kind of time frame, if we continue to see the same disconnect between the actual severity of patients and the severity of the case mix. So while we haven't gotten better in hospitalization rates, we have gotten better almost across the board in other measures of quality. So we've gotten better in our process measures, and you can see that these are all kind of upward directional. The April 17 data bumped it all up a little bit higher. Outcomes, looking at improvement rates, all heading up in some instances, a really clear trajectory in terms of the improvement that we're seeing. Again, in the April release, even higher numbers. I had to double check my numbers because I was typing them, like, did we really bump up some of these scores by another 1 or 2 points? And sure enough, we have, as a nation, in just a 3-month time span, which means that we just dropped an old quarter and added a new quarter, but most of the data was identical between those two timeframes. And yet we still see this continued upward trajectory. So it's an interesting question. If we're using all these different measures and we have this clear progress, improvement in these measures and yet not in that hospitalization measure, what does that tell us about what's really going on or the quality and effectiveness of the measures that we're using to answer that question? So we know, so the question is, we've got this conflict. So what does that tell us about how these different areas are linked together? And what I can tell you is that hospitalization rates are not statistically correlated with other areas of performance. What I mean by that is if you as an agency have higher, or agencies that overall have higher outcome rates do not necessarily have lower hospitalization rates. Agencies that have higher process measure scores do not necessarily have higher or lower hospitalization rates. Performance in those areas are not linked at the agency level. There are a couple of exceptions. We do see a slight positive relationship between an agency's ability to have a high improvement in pain rate and their lower hospitalization rates. So statistically speaking, at the agency level, that's really the only place that we can kind of say, all right, it looks like effective management of pain at an agency level may be tied to effective avoidance of hospitalizations. There is a tiny negative relationship between vaccination rates and hospitalization rates, meaning agencies that have higher vaccination rates actually have slightly higher or worse hospitalization rates, which is kind of counterintuitive, right? Now, the thing about this data is that at the agency level, we don't see those trends going together. So at the agency level, those who are good at one area are not necessarily good at the other. But at the patient level, there is clear association that patients who are vaccinated have lower hospitalization rates. Patients who had timely initiation of care have lower hospitalization rates. But we have so few patients that aren't getting those process measures at this point in time that it gets kind of a little bit skewed in terms of the sample sets. We also know that there is significant variability at the agency level. As an industry as a whole, we've been pretty darn flat, gone up even a little bit, but we know that when we look agency by agency, there is a lot of variability. The scores at the bottom represent hospitalization rates. Each bar represents how many agencies fit into that hospitalization rate. So you can see that it's somewhat bell curvy, right? We've got a relatively even distribution of agencies. 16% is right at that middle point, which is pretty consistent with our national rate overall. And then we've got a group of agencies kind of hugging that 16% between 14 and 18. The top 10% of agencies, the 10% of agencies with the lowest hospitalization rates are 10% or lower. So we know that 1 out of every 10 home health agencies can manage to have a 10% or lower hospitalization rate today. We know that the middle 50% of agencies, so kind of the core group, is in that 14 to 18 range. So half of all agencies fall there, half fall on either side of that distribution. We also know that agencies get better. So for this analysis, instead of just looking at the average improvement, we wanted to think about what does improvement look like based on where an agency starts. Do agencies who are more successful tap out? Do they not get better at a certain point? And do we see greater levels of improvement when agencies start at lower levels of success? So what we've done here is we've divided the agencies in the country into 4 groups based on their starting hospitalization rate. This first bar represents the agencies that started with the worst scores. So the 25% of agencies that had the highest scores to begin with. We know that of that group, 72% of them improved year over year. So we can get better. Looking at the next group, the 25% that had kind of middle to worse scores, so middle bad scores, half of them got better year over year. The group of agencies that were also kind of in the middle, but on the positive side of the middle, 1/3 of them got better year over year. And so you may wonder, do agencies that start with the best scores, is there any room for improvement there? And sure enough, we do see improvement. We do see that even agencies that start with some of the lowest hospitalization scores can still improve those rates year over year. We also know that in each of these groups, the lower your performance to begin with, the higher the average improvement. So the agencies in this group, not only was it 72% of them improved, but the average improvement for those 72% was higher than the average improvement for these guys, which was higher than the average improvement for those and higher than there. Yes? That is a great question. She asked about what percent stayed the same and what percent decreased. I do have that data. I don't have it in this slide set. Yes. Yes. It's. I don't remember specifically how that subset broke out, but you see kind of all these bars. If you stack them in terms of improved, stayed the same, got worse, the sizes just kind of shift as you go along. So as you might imagine, it's not like we have a consistent group in one category and this is the only area changing. Yeah, this could be a whole hour on its own. And this, I know, we really could. You should listen to our phone calls. We're like, okay, we got an hour. 2 hours later, we're like, all right. We got and the thing about this trend is that this is consistent with other areas of improvement. This isn't a phenomenon that is unique to hospitalization rates. When we look at improving performance in other outcomes, we see similar trends. Those agencies that start from a lower place are more likely to improve, and when they do, they are more likely to improve at a greater velocity. We also know that there is variability by location. This is just looking at the states with the highest and lowest rates. You can see the national norm of about 16%, and the states with the lowest hospitalization rates and the highest hospitalization rates. This may speak to factors that are somewhat or entirely out of the control of the agencies. We know that healthcare is local, that there are various factors besides the quality of the care that you provide that can influence how many of your patients go to the hospital, right? Local resources, general care providing trends in your community, patient demographics, all kinds of things. So this is a reality. Even with risk adjustment, which is applied to these measures, we still see a lot of variability in these great big chunks of agencies across the country. This is one of the data points that makes me glad that what CMS is doing on the value-based purchasing side is state-based. Because if you are in Hawaii, for example, it's not really fair to be scoring you against a national norm or against states where they have a much higher rate, because you should be achieving a higher bar relative to the peers in your community. All right, now we're going to break down and get into some patient level trends. Look at what we see across different patient subsets. And some of these probably won't be a surprise, but maybe are useful in terms of thinking about the problem from an industry perspective as well as from an agency perspective. Hopefully it's not a huge surprise to you that our chronic conditions, what we've got here is broken out our top 6 primary diagnoses, hospitalization rate for each one of those 6 groups. And hopefully it's not a huge surprise that our chronic patients with heart failure and chronic bronchitis have much higher hospitalization rates than our ortho aftercare patients, right? Not a big surprise there, but it does speak to kind of what's driving our rates as an industry overall and what might be influencing your own hospitalization rates. Even with risk adjustment, we see this same sort of variability. So if you are an agency with a really high population of ortho aftercare patients and your rate is just hitting that national norm, you're probably not doing as well as you could be. Or likewise, flip side, if you've got a lot of chronic care patients and you're struggling to meet that national norm, that could be influencing your success in that area. Now, the other thing about this I want to think about is the ability to be good in different things at different times. So it's interesting to look at the diversity across the different groups. This is my 6-year-old son. He is a beast on the soccer field. Let me tell you, he is just zoned in. He gets out there and he kills it every day. He's also playing baseball. He stinks at baseball. He is terrible at baseball. He's also new to it, but the difference watching him, you could probably even tell just by these 2 pictures, right? Watching him on the soccer field versus watching him on the baseball diamond, he's like 2 different kids. So the point here is that just like different kids have different athletic abilities in different sports, we see a lot of variability in agency level performance within some of these different breakouts. So even some agencies who have, let's say, lower hospitalization rates at a global level, and maybe even have an ability to keep more chronic care patients out of the hospital, may still have higher rates in some other patient subsets. And so many of our efforts as an industry as a whole have been on looking at global best practices. What can we do across the organization to avoid unnecessary hospitalizations across the board? And there may be a point in time, especially for some organizations, where they've maxed out their ability to improve looking at those global efforts. Drilling in to look for specific areas of opportunity may allow them to customize their improvement efforts and maybe not move the needle for the entire organization, but maybe reduce hospitalizations for a specific subset of their patient population, and in that determined focus, actually bring the rate down overall. So that's where we're starting to look at some of this variability. These are a couple breakouts and examples of that based on the patient conditions that we had a couple slides ago. So overall, our ortho aftercare national ACH rate is 8%. But we know 3% of home health agencies have no admissions in this subset, and 25% of all agencies are at 5% or lower. So there are agencies that are achieving much better than that national norm. We also know that 5% of agencies have a rate that's more than double what we see at the national level. So a lot of variability. Similarly, in that heart failure group, 4% of home health agencies have a rate less than half of the national norm, and 25% are under 22%. That's a lot bigger difference when we're talking about heart failure looking at the overall rate compared to that kind of top tier rate than at the ortho aftercare because of kind of where those rates are to begin with. But we have, I think, a lot of opportunity to move the needle in some of these groups as demonstrated by some agencies' success. This is our data, yes. This is looking at another perspective. So here we, instead of breaking out patients by the primary diagnosis, we are breaking out patients based on their risk level, their assessed risk at start of care. And again, this is one area, I have a lot of clients who have paid attention to condition-specific programs. They know that they're putting some interventions specifically in place for their orthopedic patients or for their heart failure patients. But looking at it from a perspective of risk can give additional depth to their understanding. So here on this slide and another one, we've broken it out to look at the 25th percentile, the 50th, and the 75th. So you can see kind of the variability at the agency level within each of these groups.
This start of care risk level, this is an algorithm that you have applied to your data.
Correct. We have applied the statistical risk assessment at the start of care and then used that to break patients out. And if you are not a data geek, if you don't look at this stuff all the time, let me just quickly break down what this means. If we're looking at patients with a moderate risk level at start of care, the median readmission rate at the agency level is 16%. So the agency is right in the middle at managing their moderate risk patients. They have a hospitalization rate of 16%. Agencies who are in the top 25th percentile, they have the lowest rates for this subset of patients based on moderate risk level. They have a 13% or lower. Agencies with the highest have a 19% or higher. So that's what you're looking at here in case you're interested in kind of taking some of this information back and looking how it relates to what you're focused on as an organization and if you have opportunities to improve. But I could tell you, like I said, I work with a lot of clients who already have condition-specific programs in place. But when we break it down and we look at things like risk level, I actually have clients who do a really good job of keeping high-risk patients out of the hospital, and yet they have higher hospitalization rates for their low-risk patients. So the interventions that they've put into place are really good at identifying those higher-risk patients and managing them effectively, and the lower-risk patients have just kind of gotten left behind a little bit. So that's the value in kind of digging in and looking more deeply at some of these different breakouts. So most agencies have strengths and opportunities for improvement. We don't always have consistency across the board. There are some kids who are crummy at sports altogether and some kids who are great at all sports, but most of them are actually good in some areas and have more opportunity for growth in others, and honing in on those that have opportunity for improvement may help us improve our athleticism overall. I don't know, that analogy is kind of running its course here, but I think you get the point, right? All right. So here's another breakout, looking at a couple of other patient characteristics. We've got inpatient facility discharge, so those patients who are in a hospital prior to home health, who are in a nursing home or rehab facility, or who had no inpatient location prior to home health. Hospitalization risk factors, and other clinical conditions. Here we looked at non-healing surgical wounds, fully dependent in oral meds, dyspneic at rest, just as some key kind of clinical factors that may speak to impact on hospitalization rates. And you can see again the variability. Some of these have tighter ranges. We've got here a range from the low 25th percentile to the top 75th percentile, just 8%. But in other places, we have wider ranges. We have 14% in terms of being able to avoid readmissions here in this group here. So there's where we see a lot of variability is in how agencies are able to manage patients who are in a hospital prior to home health. The median level there is 30%, but our top 25% are at 24 or less, and our bottom 25% are at 38 or higher. Another thing that we can look at is kind of variability, not by patient groups, but by different dynamics. This is another area where we've identified some really interesting patterns. What you have, this one and the next one, what you have here is the hospitalization by week of care. Like I mentioned earlier, we see a lot of hospitalizations in those first few weeks. They tend to drop off after that. So that's why we see just a slight bump from the 30-day readmission rate to the 60-day ACH rate. But even in being able to manage and avoid hospitalizations in that first week of care, we see a lot of variability. Some agencies are really successful at avoiding hospitalizations early on. Some are struggling with that more. Yes, ma'am. Okay.
The process measure, which is timely initiation of care, is there a correlation between that and rehospitalization? If so, what is it?
The process measure, timely initiation of care, and is there a correlation between that and hospitalization? I could tell you a few years ago, that was the strongest correlation, was timely initiation of care, hospitalization, and actually patient experience. Timely initiation of care was most tightly tied to those other outcomes. As agencies have gotten better at managing timely initiation of care, that correlation has decreased. Yep. Now, it's got lots of other benefits around referral management and all kinds of other aspects of success, but.
Yeah, but there's also, I think, somebody was commenting to me, and I've been away from it for a little while, but they were saying that people, that agencies still do manage that measure by calling in for an extension on that.
Calling in for an extension, and that's actually appropriate in some situations by the CMS guidelines. So, but it's a great question, and one thing that I have on my list of things that I want to research is the days between hospital discharge and home health admission. So it's not specific to the timely initiation of care measure, but yeah. Yep. Yes.
Have you done any correlation with how agencies are either freestanding or in an integrated system, whether integration has
Do you want to talk to that one? So the question is if freestanding versus part of a health system is related to hospitalizations.
Stay tuned for phase 2. So really what we'll talk about at the end of there's a little bit more data that we wanted to share today, but really where we're going with this overall is that we wanted to share what Christy and I have been working on in terms of trying to understand what we know right now. And that is helping us to identify what else do we need to know? What are the next level questions? We really started with, if these are the process measures we collect, then they must be useful to keeping people at home. And we're not finding that. And that's really important finding because it means we have to start to look for other things. What really are the variables that are helping to keep people at home? And so this work here is starting to dig into what could be the subsets, what directions can we go in? Is it based on location or diagnoses or timing of discharge, and trying to look for some patterns that would help us go to the next level. So at this point, my answer is no, we haven't done it, but it is on the plate.
Look at, we don't have many privileges that I know of, so the relationship with the physician has to be admitting. I mean, how many physicians do you call and they don't even listen to you when you say pregnant?
Right.
Did we use the day of the week in here? Okay, well, we've got some interesting data on the days of the week that people get admitted as well. I think you all know where we're going with that one. But your point is really valid, and that is some of what we see as data that isn't easy to get, but we have to figure out how to get it. So part of what we're really starting to do here is to say, what do we know? What do we need to know? And then how are we going to collect data that hasn't been collected yet? Because that is one of those things that I think instinctually a lot of people say communication patterns, whether it's between the patients and the home care teams and the physicians, or anywhere in that triad is going to play a role in this. But how do we measure and collect data in that way that could be useful to this sort of comparative guidance? And we're just not there yet. So I do want to let Christy go.
Does legal liability factor into, that return to the hospital?
Does legal liability factor into that return to the hospital? And Danielle, you don't know. Does anybody know the answer to that question? Yes, sir. Doctors are worried about their own liability.
You call them and say that you're not feeling well, they'd rather
than risk it. Yeah.
I think that's very true. The state that you're practicing. So I started in Utah, went to California, went to Texas, and I will tell you, California, the drop of a hat, there is in
So you can validate some of those trends by state. You've seen local trends, local mentality or practices or availability of resources in action.
And I think, how willing are physicians to aggressively treat in the home because of a liability standpoint? And the things that physicians would allow us to do to keep a patient in the home in Utah is vastly different than what they do.
Do you think that was a cultural thing or a malpractice insurance thing or?
I could not separate those out.
Okay.
Because I think culture leads to malpractice.
Sure.
It's of society.
Yeah.
So,
How they're getting reimbursed too.
And their reimbursement?
There's still a fee for service, they have productivity. What's incentivizing them to have? So it's not only a state with legal issues, but if they're losing income because they stay at home, they're gonna say bring them in so
Yeah.
they can get more.
And that gets to aligning all providers across the continuum.
We have a lot of patients in assisted living, and what we're finding is there's no incentive for the assisted living not to send them to the hospital if they think something's wrong. So fully 30% of our hospitalizations last time we did an audit were sent from assisted living. So.
And if you have a larger than average patient population in that mix, and you talk about liability in that world right now.
Okay, so all of you have signed in today. Just so you know, you're on the short list of people that I'll be calling. You've just all volunteered because what you've laid out here is about 5 lifetimes of research scientists' careers. And we need that. I mean, I'm so excited about this because we were hoping that showing you some of this data would spark some of this. It could be this, it could be that. And this is the way that researchers can start to follow the trail and try and unlock some of this information. So just for the sake of time, because there's a couple more things you're really going to want to see, I'm going to let
All right, and I'm almost done, then we could just continue conversation as we want. All right, so speaking of percent hospitalizations by day of the week. Is this something that you all have looked at within your own organizations? Okay, so sometimes this surprises people. You seem to be a little bit ahead of the curve, but hospitalizations happen more often during the week than they do on weekends. But we do, again, even see some variability. Here we've looked at the 80th percentile, and I could tell you that when you've got somebody who has a spike, and they may have an 80th percentile on Thursday, but they actually have a really low rate on some of these other days, and they can look at that and say, all right, what is it about us on Thursdays? Is it, or I can recall a conversation I had a couple weeks ago on about a Tuesday spike. They had actually lower rates on most days, but a spike on Tuesdays. And they were thinking about their weekend admissions. They were thinking about who is on call, who's manning the phones that night, and thinking about all these different factors that could be potentially triggering that spike. And if there was something that they could do to bring that spike down, could that lower their rates as an agency overall? All right, and the last one, this one isn't in your handouts because I didn't have it quite in time to make the deadline, so I wanted to refresh it. It's one that we've done in the past, but this starts to think about practice patterns because, of course, what I've just done is looked at different patient characteristics, different agency characteristics, and what Danielle and I talk about is the need to have a deeper understanding of practice patterns, whether that's the skill level of the clinicians involved or what you're doing on different visits or how frequently they're happening or those sorts of things. We have an emphasis on the concept of front-loading visits, and what you see here is looking at the 60-day ACH rate based on the number of visits that the patient receives during the first week of care. And we've actually taken out anybody who was hospitalized during the first week of care, so we wouldn't include them if they only got one visit and then they were hospitalized 3 days after admission. But this seems to validate the fact that having more visits up front, at least to having 3 visits, leads to or is associated with lower hospitalization rates. Biggest difference, of course, being between only getting 1 visit that first week and getting 2 visits that first week. So we have broken this down by different conditions, and we see this same trend with different numbers. And with some conditions, you see more of a drop between that second visit and that third visit, and others you see less delineation in those different breakouts. So this is starting to validate what we have, but it's really only scratching the surface. And that really gets to this question of what do we not know? We don't know anything about caregiver skill level, about what best practices or clinical protocols these organizations are using, what technology they're using. We don't have a great understanding and certainly struggle to even think about how do we collect this aspect of how these different providers interact with each other and what impact that has on readmission rates, or getting to the point you just made about collaboration and communication, home health, physicians, patients, their families, the hospitals, all of that kind of loop and that ecosystem there. And that's all the data I have, so we can talk now, unfettered. Patient behavior. Although I heard a really great, okay, sorry, I'm not going to do that because it's just a silly little thing that I heard yesterday. Oh, it's just, okay, so you're talking about patient noncompliance. Somebody used this example yesterday. How many of you have been out of town for one night or more in the last year? How many of you who, keep your hands up, how many of you who do that, do some daily thing to manage your health, whether it's take meds or vitamins or exercise or certain foods? How many of you kept up that protocol when you were out of town? Yeah, everybody who just dropped their hand, you are now non-compliant. So everybody else, give yourselves a pat on the back. That was pretty, actually, let me just tell you, in terms of benchmarking, the group in Arizona yesterday, there were only 2 people who still had their hand up at the end of the day. So you guys are above average, but yes.
Yeah. Okay, your turn. We haven't dug into it enough yet to put it up there, but it is on our radar. The other component that's on our radar is the observation status. Anyone who knows hospitals knows that's the biggest get out of jail free card ever. It's also a huge patient dissatisfier, and I say that after 18 years in hospitals. That is a nightmarish game that gets played, and we don't understand how that impacts this.
I thought the level of detail in this data was awesome. Do you have any idea if CMS is going to start including that on our home health prepared, like per diagnosis category, our rehospitalization rate? That'd be a great way.
I would be surprised. No. I don't know about any plans for sure.
I doubt it, but I think that one of the big, hairy, audacious goals that we're trying to move towards is the creation of information that we can then use to push CMS in a direction that shows us in a different way. You know, we have been really not having an opportunity because we didn't look at the data independently, and by we, I mean a collective home care body of research, that CMS and regulatory bodies were working with what data they had. And I think this comes back to the conversation we had about, well, which it's a chicken and the egg. Did MedPAC say stuff and then we got data? Or did we have data that was maybe not well understood, or it was very skimming the surface, which led to MedPAC making certain statements? So I don't see at this point either of us have any reason to think that CMS is changing what they're doing. But I know that it is our goal to help them want to change, because we collect some information and we demonstrate that the different things are more important. And, you know, if the process measures that we're all collecting and using and getting 5 stars in our value-based purchasing is really not changing the ability to stay home, then those probably aren't the things that our revenue should be based on. But we have to start that conversation. So we're trying to take it from the other angle. Instead of letting them say this is what we want, we're hoping to try and push them in the other direction. Dan, you.
These models are really good. Is it possible, or is there value to compare the visiting nurse organizations to the industry, using these models, or is there?
Yeah. There's an awful lot of question around how the structure of an agency may or may not influence this stuff. And what I can tell you right now is it's on the list of things to be understood and examined. We haven't done it yet.
We see a lot of lousy medical care that's not adherent to best practices on the medical side. And I think that's what we're looking at.
I'm writing that one down.
Yeah, that's yours. Yeah. All right, sir, your turn.
If you're an ability customer already, is there an opportunity for you to push these reports to us?
I would love to put a pin in that and talk to you about it in just, or call you. Okay. This isn't about us, but I appreciate the question, so thank you. Any other questions or items for Danielle's list? Caregivers.
There's so much pressure from the shorter discharges and a lot of our
Staff, caregiver staff, or like non-staff caregivers, families. Yeah.
On Friday afternoon after 2 o'clock. I may be the unpopular one in the room, but I hear a lot of the hospitals are discharging a lot faster and they're sicker. And as an agency, we're working really hard to like lean into that and embrace it and figure out what does that mean for us, as opposed to like hanging our hat on that. And so I love the idea of you guys looking into what are the things that really are impacting it, because obviously what we're looking at, it doesn't have a correlation, and it's not helping us find that secret sauce to really be able to keep patients at home. And I'm a huge proponent of a lot of what we send our patients back to the hospital, we should be able to handle in the home. We should be able to really put a lot of the acute settings out of business outside of ICU and surgery.
Can we say amen? I really want to applaud you for your reverse thinking on that, in that, it's kind of my theory of fire swamp. Does anyone remember Princess Bride? And, there were 3 things that happened in the fire swamp, and no one thought that they could live through it. Well, if you knew the 3 things, you could live forever in the fire swamp, right? So we could sit here and say, oh, bad hospitals, you're discharging people too soon. Or we could say, oh, good hospitals, you're getting people home. Let us help you get them home. And that is a radically different way to think about this if we stop thinking about the readmission, because that is the failure mode. If the patient is admitted, we have failed, right? So how do we make it positive and say the goal here is to stay home? So let's tap into what can we do to keep people at home and keep increasing the likelihood of doing that. I know we're out of time and people need to get to the airport, and I do just need to say this. Remember everything you just said, hey, can you look into, and what about this variable and that variable? Yes, but that means you're going to have to share information, because I can't just pull this stuff out of the air. So at some point, there's going to be an ask back about, hey, can you collect, can you share, will you take part in giving data so that it can be analyzed, so that it can be included in this analysis. And I'm so excited to see you all shaking your heads and going yes, and seeing that that's a really worthwhile thing. So thank you so much for that. I also really just want to take a moment to thank you for coming to San Diego, for taking part in our National Leadership Conference. I know I've had an amazing time, and I'm so excited that you all were here. I hope you will consider joining us also for our Financial Leaders Forum and our Public Policy Leadership, and see you hopefully next year at our National Leadership Forum. Thank you all so much.